Assalamualaikum and good day everyone. We are from Group 3 and today we will be presenting our study entitled Heart Failure Prediction Dataset. First, let me introduce our group members. My name is Nilimi Sarabunti Sarisam. Next is Isna Atisha binti Ismail, Nurahika binti Abdul Hamid, Nuriyah Fatima binti Ghazali, Sharmin Shahriya binti Fandi. This presentation is prepared for STA406 Statistic for Applications. Now, let me begin with the introduction of our study. Heart disease is one of the leading causes of death worldwide and continues to be a major public health concern. It affects millions of people every year and is associated with various risk factors, including lifestyle habits and existing medical conditions. Early detection and proper assessment of heart disease are essential because they allow healthcare professionals to provide timely treatment, improve patients' quality of life, and reduce the risk of serious complications. For this study, we used the heart failure prediction dataset obtained from KAC. The dataset contains demographic and clinical information collected from individuals and is commonly used to study factors associated with heart disease. By applying statistical analysis to this dataset, we can gain meaningful insights into the characteristics of the individuals and examine relationships within selected variables. The objectives of the study are: first, to describe the demographic and clinical characteristics of individuals in the study. Second, to determine whether individuals with heart disease have a higher mean maximum heart rate than individuals without heart disease. Third, to examine the effect of cholesterol level on maximum heart rate among the individuals. The findings of this study are beneficial to healthcare professionals because they provide a better understanding of the factors associated with heart disease, which can support early diagnosis and treatment decisions. Researchers may also use the findings as a reference for future studies on heart disease prediction. In addition, the public can gain greater awareness of the importance of monitoring health indicators and maintaining a healthy lifestyle to reduce the risk of heart disease.
Biology Part A, Dataset Explanation. The source of data for our study is secondary data obtained from KAC, specifically the heart failure prediction dataset. While the original population consists of 918 records, our group narrowed the scope to a final sample size of 200 observations, using random sampling to ensure efficient data management. The variables utilized in these studies is age, gender, cholesterol, resting blood pressure, max heart rate, and also heart disease.
Now, I will explain the method of analysis used in our study. For objective 1, which is to describe the demographic and clinical characteristics of individuals in the study, we use descriptive analysis. The variables involved are age, resting blood pressure, cholesterol, maximum heart rate, gender, heart disease, and fasting blood sugar. For continuous variables, namely age, resting blood pressure, cholesterol, and maximum heart rate, we summarize the data using the mean and standard deviation. While for the categorical variables, which are gender, heart disease, and fasting blood sugar, we use frequency and percentage to describe the distributions of respondents. For objective 2, which is to determine whether individuals with heart disease have a higher mean maximum heart rate than individuals without heart disease, we use the independent sample test. The variables involved are maximum heart rate, which is the dependent continuous variable, and heart disease, which is the independent categorical variable. Lastly, for objective 3, which is to examine the effect of cholesterol level on maximum heart rate among individuals, we use simple linear regression. The variables involved are cholesterol as the independent variable and maximum heart rate as the dependent variable.
The software used in this study is IBM SPSS Statistic. SPSS is a statistical software widely used for data management, statistical analysis, and hypothesis testing. It enables researchers to organize data efficiently, perform both descriptive and inferential statistical analysis, and generate tables and graphs accurately. Therefore, SPSS is an appropriate tool for analyzing the heart failure prediction dataset and producing reliable results.
Moving on to result and discussion for objective 1, which is to describe the demographic characteristic of our individuals. Based on the SPSS output and pie chart shown on the slide, the majority of our respondents are female, accounting for 145 individuals or 72.5%. On the other hand, males only comprise 27.5% with 55 individuals. As a crucial statistical note, gender is a categorical variable. Utilizing frequency distribution and percentages provide a much more accurate and logical description of the data compared to using numerical means. Finally, let us look at the age profile of our respondents, which is a continuous numerical variable. The descriptive statistics show that the mean age of our 200 respondents is 48 years old with a standard deviation of 8 years. The age of the individual range from a minimum of 29 to a maximum of 66 years old. Overall, this distribution indicates that our study sample is predominantly composed of middle-aged adults. This value gives us a highly reliable baseline understanding of the sample age distribution before exploring further clinical trends. That's all from me for the baseline demographic profile. I will now pass the presentation to next person to elaborate further on the clinical characteristic.
I will now present the clinical characteristic of respondent for objective 1. To describe the clinical characteristic, descriptive statistics were used because the objective aimed to summarize the respondent's clinical profile. The numerical variables, which are resting blood pressure, cholesterol level, and maximum heart rate, are described using the mean and standard deviation. Based on the SPSS, the average resting blood pressure is 132.68 mm per mercury. This means that on average, the respondents have mildly elevated blood pressure, indicate that their heart are working slightly harder than the ideal level. Next, the mean cholesterol level is 247.17 mg per deciliter. The relatively large standard deviation indicates the cholesterol level vary among respondents, where some have level close to normal and others have much higher value. Lastly, the average maximum heart rate is 138.38 beats per minute. The standard deviation shows that respondents' maximum heart rate vary depending on their individual fitness level and response during the testing. Next, I will discuss the categorical clinical variables, which are heart disease and fasting blood sugar. Since these are categorical variables, they are described using the frequency and percentage. Based on the SPSS frequency table, 127 respondents, or 63.5%, do not have a heart disease, while 73 respondents, or 36.5%, have a heart disease. This shows that about 2/3 of respondents are free from heart disease. For fasting blood sugar, 182 respondents, or 91%, have normal fasting blood sugar level, while 18 respondents, or 9%, have elevated fasting blood sugar level. This indicates that majority of respondents maintain a normal fasting blood sugar level, while only a small proportion may have a higher metabolic risk. In conclusion, the descriptive statistics provide a clear summary of the respondent clinical characteristic. Overall, although the most respondents do not have a heart disease and maintain normal fasting blood sugar level, the average resting blood pressure and cholesterol level suggest the presence of potential cardiovascular risk factor.
Next, I will present objective 2, which is to determine whether individuals with heart disease have a higher mean maximum heart rate than individuals without heart disease. To answer this objective, we use an independent sample test because we are comparing the mean maximum heart rate between two independent groups, which are individuals with heart disease and without heart disease. First, let's look at the group statistic. There are 127 individuals with heart disease and 73 individuals without heart disease. This means that the mean maximum heart rate for individuals with heart disease is 143.34 beats per minute, while the mean for individuals without heart disease is 129.75 beats per minute. This indicates that, on average, individuals with heart disease have a higher maximum heart rate rather than those without heart disease. Now, before interpreting the p-value test, we need to check the Levin test for equality of variances. Step 1. The hypotheses for Levin test are H0 is the variances of the two groups are equal, and H1, the variances of the two groups are not equal. Step 2. We use significance level of 0.05. Step 3. The p-value from leaving test is 0.597, which is greater than 0.05. Therefore, we fail to reject the null hypothesis and conclude that the variances are equal. Since the assumption of equal variances is made, we refer to the equal variances assumed row in the independent sample test table. For the p-value test, it shows two variables which are maximum heart rate and heart disease. Step 1. The hypotheses are H0, the variances of the two groups are equal. H1, the variances of the two groups are not equal. Step 2. We use significance level of 0.05. Step 3. Since the p-value which is 0.000 is less than 0.05, we reject the null hypothesis. Therefore, there is a significant difference in the mean maximum heart rate between individuals with heart disease and individuals without heart disease. In conclusion, individuals with heart disease have a significantly higher mean maximum heart rate rather than individuals without heart disease.
For the third objective, we aim to examine whether cholesterol level affect the maximum heart rate among individuals. To achieve the objective, we use an independent sample test because it is suitable for comparing the mean of a continuous variable between two independent groups. In this study, the independent variable is cholesterol level, which is classified into low cholesterol and high cholesterol, while the dependent variable is maximum heart rate. Before interpreting the t-test, we first check leaving test for equality of variance. Since the significance value is greater than 0.05, the assumption of equal variance is met. Therefore, we use the equal variances assumed result for our interpretation. From the group statistic table, we can see that individuals with low cholesterol have a slightly higher average maximum heart rate than those with high cholesterol. However, the independent sample t-test shows that the two-sided p-value is greater than 0.05, indicating that this difference is not statistically significant. This means the difference is likely due to random variation rather than the effect of cholesterol level. Therefore, we fail to reject the H0, which states that there is no significant difference in the maximum heart rate between two cholesterol groups. These results may occur because maximum heart rate is influenced by many other factors such as age, physical fitness, lifestyle, and underlying health constitutions rather than cholesterol level alone. In conclusion, the results show that cholesterol level does not have a statistically significant effect on maximum heart rate among the individuals in the study. Therefore, the third research objective was not supported as there is insufficient evidence to conclude that the maximum heart rate differs between the individuals with low and high cholesterol. Next, I would like to present about the recommendations. First, we recommend promoting healthy lifestyle by encouraging regular physical activity, a balanced diet, and a routine health screening. Since a considerable proportion of the respondents were diagnosed with heart disease, adopting healthier lifestyle habits may help reduce the risk of cardiovascular disease and improve overall heart health. Second, future studies should include additional risk factors such as age, body mass index, smoking status, physical activity, and medication use. This is because our findings show that cholesterol level alone was not significantly associated with maximum heart rate, suggesting the other factors may have a greater influence on cardiovascular health. Finally, we recommend conducting future research with a larger and more balanced sample size. This will improve the reliability and generalizability of the finding, especially when comparing individuals with different cholesterol levels. Overall, these recommendations can help improve future research and support more effective strategy for preventing and managing heart disease. In conclusion, this study successfully achieved all three research objectives. First, it described the demographic and clinical characteristics of the respondent, showing that the most with principal did not have heart disease and maintained normal fasting blood sugar levels, although the average cholesterol level was relatively high. Second, the analysis found a significant difference in the maximum heart rate between individuals with and without heart disease, indicating that the heart disease status is associated with maximum heart rate. Finally, no significant difference was found in maximum heart rate between individuals with low and high cholesterol level, suggesting that the cholesterol level alone does not significantly affect maximum heart rate. Overall, these findings highlight that heart disease status has a greater association with maximum heart rate than cholesterol level, and future studies should consider other factors that may influence cardiovascular health. So that's all from us. Thank you.